Urgent, measured tone. A 45-year-old African-American woman arrives at the ER reporting a severe headache and fatigue. Her blood pressure is dangerously high at 190/110, and her creatinine has tripled overnight to 2.6 milligrams per deciliter. She has a history of systemic lupus erythematosus, previously marked by a subtle malar rash and episodes of hemolytic anemia. This combination of malignant hypertension and a rapid creatinine spike indicates that her kidneys are actively failing. This is a catastrophic glomerular event. The medical team has a window of only a few hours to intervene. If the inflammation isn't stopped immediately, her renal function will be permanently destroyed. An examination of the patient's urine reveals 25 dysmorphic red blood cells per high-power field and heavy 2+ albuminuria. These red blood cells are physically deformed and biconcave, a state that only occurs when they are forced through rupturing glomeruli. This finding locates the bleeding in the kidney itself rather than the lower urinary tract. This table categorizes lupus nephritis by severity. Hematuria, proteinuria, and a decreased filtration rate point directly to Class 3 or Class 4. Class 4 features diffuse, generalized hypercellularity within the mesangial and endothelial cells, and the early formation of cellular crescents. This active sediment indicates the delicate capillary tufts are under immediate attack, a process that leads directly to end-stage renal disease. Deep inside the renal cortex, the delicate capillary tufts within Thoman's capsule serve as the kidney's primary filter. The crisis begins when high-affinity anti-dsDNA antibodies bind to nuclear antigens, creating bulky immune complexes. These complexes lodge themselves into the subendothelial space, forming the thick, wire loop lesions that define severe lupus nephritis. The presence of these complexes triggers the C3 and C4 complement cascade, a chemical alarm that recruits neutrophils and macrophages. These cells gather into suffocating crescents that surround the capillaries. As these crescents expand, they physically crush the capillary lumens. This cuts off blood flow to the nephrons and initiates irreversible scarring. The traditional clinical instinct is to wait for a definitive renal biopsy before starting heavy-duty immunosuppression. In this specific case, that delay is often fatal for the organ. Within days, active cellular crescents calcify into permanent fibrotic tissue that no longer responds to treatment. The protocol for an immediate rescue combines a massive IV pulse of 1,000 milligrams of methylprednisolone with oral mycophenolate mofetil, or MMF. On the left, the methylprednisolone pulse saturates glucocorticoid receptors, shutting down the NF-kappa B pathway, stopping inflammatory cytokine production within 24 hours. Simultaneously, MMF inhibits the IMPDH enzyme, severing the purine synthesis pipeline that T and B cells need to proliferate. When an autoimmune flare threatens immediate organ failure, pulse steroids must never be withheld to wait for a biopsy. For decades, intravenous cyclophosphamide was the standard induction therapy. Today, however, many protocols have shifted toward MMF. This change was driven by the results of the Espriva lupus management study, known as the ELMS trial. The trial data showed that MMF achieved significantly higher renal response and remission rates, specifically in African American and Hispanic populations. MMF also offers a superior safety profile, preserving ovarian reserve and avoiding the bladder toxicity associated with cyclophosphamide. Treatment is now tailored to the individual, using the specific immunological tools proven most effective for a patient's demographic and genetic background. In refractory cases, physicians are now turning to what is known as triple therapy. This regimen includes belimumab, a monoclonal antibody that intercepts soluble BAFF ligands before they can stimulate autoreactive B cells. It is combined with voclosporin, which stabilizes the podocyte slit diaphragms in the kidney to rapidly stop heavy protein loss. This multi-pronged stabilization allows the glomerulus to clear inflammation and restore blood flow without destroying the patient's entire immune system. In the race against fibrosis, immediate empiric treatment is the only way to save the organ.